let's start with sarcoidosis. Okay. What is sarcoidosis? It is characterized by immune-mediated, widespread, non-caseating granulomas, high yield, because it's going to be as comparison with your tuberculosis, and we will talk about that. So what else you're going to see? You'll see elevated serum ACE levels, elevated CD4 CD8 ratio in bronchoalveolar lavage fluid, more common in blacks, females. So young black female, you see it in history, with increased ACE, increased calcium, with non-creating granuloma. Think about sarcoidosis, right? Most often asymptomatic, except for enlarged lymph nodes. Chest X-ray would show bilateral adenopathy and coarse reticular opacities, picture B. So we do see coarse reticular opacities all throughout the lung. CT of the chest better demonstrates the extensive hilar, again goes back to tuberculosis, hilar and mediastinal adenopathy. So let's now just highlight particular features here. We're looking at non-caseating granuloma. We are looking at increased ACE, increased CD4, and we are also looking at hilar lymphadenopathy, right? And differentiate this versus tuberculosis is, so tuberculosis, it's instead of non-caseating, tuberculosis will be caseating granulomas. Other thing would be that it's going to show a nodular shadow in the upper lobes. And here all we have is coarse reticular opacities. But in tuberculosis we will have a nodular shadow, which is like a gone focus and gone complex when you associate the hilar lymphadenopathy together. So nodular shadow will be seen in the upper lobes. Okay. What is this thing is associated with, and what very high yield that is just specific for this disease is this right here, young black females, high yield. Okay, now let's look at what is it associated with. It's going to be associated with Bell's palsy, peritoneal enlargement, granulomas, non-caseating, epithelioid containing microscopic Schwann and asteroid bodies. Schwann and asteroid bodies. Rheumatoid arthritis like arthropathy, increase in calcium, high yield. Skin changes, lupus, pernio, and erythema nodosum. Pneumoconiosis, sarcoidosis. Sarcoid, my bad. Sarcoids, and you can memorize sarcoids from here. But why do we have increased calcium here? That's important. A lot of questions are just on increase in calcium. So we have increase in calcium in all granulomatous diseases because those multinucleated giant cells, they make 1-alpha hydroxylase enzyme. And that 1-alpha hydroxylase converts the inactive vitamin D to active vitamin D. And that is in your biochem section, by the way. You can look at it, vitamin D, and it's going to be there, or in your endocrine, in which there is a PTH. Both are same there. So 1-alpha hydroxylase is going to act here, make active vitamin D, right? And that active vitamin D is going to cause calcium, increase in calcium in the body. So that's why you have increase in calcium, and this is very important because it's only seen in granulomatous diseases, right? So what is the treatment for sarcoidosis? Is glucocorticoids, if symptomatic. Okay, so what else? So you might have some extra points. Yeah, one more thing extra here is about CD4. Here's what we have. So CD4 cells are going to release which cytokines here? It's going to release interferon gamma, INF, gamma, and your tumor necrosing factor alpha. Eventually, these things are causing macrophage activation, and that macrophage activation causes multinuclear giant cell, causes granuloma formation. Okay. It also resembles sarcoidosis, also resembles interstitial lung diseases, because of all of this granuloma with reticular opacities and all that. So how do we know? How do we differentiate that? And how do we differentiate these things? So we do BAL, which is your bronchoalveolar lavage, and in bronchoalveolar lavage, if you have increase in CD4 count to CD8 count ratio, then you right away think about sarcoidosis. So BAL, which is right here, bronchoalveolar lavage, where is it? Bronchoalveolar, yeah, right here. Let me just highlight this thing. So this would differentiate all the interstitial lung diseases versus sarcoidosis. And this sarcoidosis also looks like tuberculosis, so you can differentiate through that. Okay. And non-caseating granuloma is right here. What is non-caseating? You have cells which are here present, and they are non-caseating. It's not caseous. If you look at picture C, what do we have? Look at the hilar and mediastinal, most likely here, mediastinal lymphadenopathy. Okay, so let's review this quick and move on to the next one. Sarcoidosis, simple words, immune-mediated non-caseating granuloma, increased ACE levels, increased CD4 levels, seen in black females. It's gonna be in your, you will see hilar lymphadenopathy, reticular opacities, and it is associated with sarcoids, most specific, most high yield, increase in calcium, and data is due to vitamin D activation due to 1-alpha-hydroxylase in macrophage. Treatment glucocorticoids. And that's all for sarcoidosis. Moving on with the next one is called inhalational injury. Inhalation injury and the sequelae of that. So it's a complication of inhalation of noxious stimuli, for example, smoke. It is caused by heat, particulates, which are less than 1 nanometer, micrometer, I don't know, but it's a very small particle. Actually, let me just double check what it is. Give me 1 second. Microns, my bad. Okay, so it's less than 1 micron. So this right here is a micron. Okay. So any particle which is less than 1 micron in diameter or irritant like NH3 leads to chemical tracheobronchitis and edema. Again, what did we talk about? We said if you inhale anything, you're going to lead to injury and it's sequelae of that. So what are you inhaling? Inhaling of noxious stimuli like smoke, and what injury you're going to cause is by heat and particulates, which are less than 1 microns, and irritants, NH3, can lead to tracheobronchitis edema. Also pneumonia, ARDS. Many patients present secondary to burns, CO inhalation, cyanide poisoning, arsenic poisoning, singed nasal hairs, or soot in the oropharynx is common on exam. This is high yield. Bronchoscopy shows severe edema, congestion of bronchus, and soot deposition. Again, soot is there, which is in picture A. You can see all that soot deposition. 18 hours after inhalational injury. Resolution at 11 days after injury. So it's sort of an acute thing that you will see, but there is within 2 weeks you have the resolution after injury. So if you have, I mean, you think about if there is any noxious stimuli messing up, causing the inhalational injury, you think about all of these, and you say, okay, tracheobronchitis, or anything can happen actually. But you will see a singed nasal hairs a suit present uh, on the examination. Then the next one you have is mesothelioma. Mesothelioma is a malignancy of pleura associated with asbestosis. May result in hemorrhagic pleural effusion, which are exudative, and pleural thickening. So three things mesothelioma leading. The first thing is it is associated with asbestosis, and it results in one thing hemorrhage, which causes pleural effusion, and also causes pleural thickening. Histology may show pneumoma bodies. EM may show polygonal tumor cells with microvilli, desmosomes, tonofilaments, and calretinin and cytokeratin 5/6 positive in almost all mesotheliomas. So high yield. So mesothelioma is the calretinin and cytokeratin 5/6 positive. So maybe make a mnemonic out of this. I don't know how, but calretinin plus cytokeratin. All mesotheliomas. Okay, I'll make some mnemonic out of this and post it in the group. Or if you guys can make some mnemonic, that would be great too. These things associated with mesotheliomas. Negative in other most carcinomas, tobacco smoking is not a risk factor. High yield point, it is associated with asbestosis, causes hemorrhage, pleural thickening. You will see some of my bodies. Calretinin, cytokeratin positive. Tobacco smoking is not a risk factor for mesothelioma. So let's look at pneumoconiosis. Pneumoconiosis, or we have asbestosis from the roof, was common in insulation, but affects the base. So asbestosis, which you get the poisoning from roof stuff, but it affects the base, which are the lower lobes, while silica, coal, and berries are from the base, the earth, but affect the roof, meaning upper lobes. So let's look at each one of them. The first one we have is asbestos related diseases. Asbestos causes asbestosis, simple, which is, in other words, pulmonary fibrosis, pleural disease, malignancies associated with shipbuilding, roofing, plumbing. So shipbuilding, roofing, plumbing. Other thing that you might want to know are your insulation construction. So construction, insulation, insulation manufacturing, manufacturing appliances, drywall, very high yield drywall application, and textile. Okay, ivory white calcified supradiaphragmatic and pleural plaques are pathognomic. Okay, very high yield. Again, what is it? As an ivory white calcified supradiaphragmatic and pleural plaques are pathognomic. Let's look at picture A, where we have that. Okay, this is picture A. Okay, so what do we see? We see pleural plaques, opacities, pleural plaques, which are known as opacities, right? Right here, right here, right here, right here. And they're going to be above the diaphragm, and they're ivory white in color. And this, if you see it, you could right away tell it's asbestosis. What are the risk factors for asbestosis? The risk of bronchogenic carcinoma is greater is greater than the risk of mesothelioma. So in other words, they're trying to say, okay, risk of bronchogenic carcinoma is more with asbestosis. Then there's risk of mesothelioma with asbestosis. There is increased risk of Kaplan syndrome, which is rheumatoid arthritis, pneumoconiosis, intrapulmonary nodules. Affects the lower lobes. Asbestosis, ferruginous bodies, high yield or golden brown fusiform rods resembling dumbbells found in alveolar sputum sample visualized under Persian blue stain, picture B, often obtained by bronchoalveolar lavage. Again, that bell. Increased risk of pleural effusion. Okay, let's look at that ferruginous bodies in picture B. Okay, here's the ferruginous body. And it is golden brown, fusiform rod resembling dumbbells. Okay, so it is like a rod, I guess. Yeah, so a rod, ferruginous body associated with asbestosis. Okay, and also increased risk of pleural effusion. Okay, now important things. Okay, let's talk about some more extra stuff. So extra stuff here we have, so asbestosis is mostly the patient with asbestosis, they will be asymptomatic for about 20-30 years. So somebody who's working here, he's going to be asymptomatic for 20 to 30 years, you know. And then they will develop clinical manifestations. Okay, and what else? Inhalation of the asbestos fiber causes epithelial injury. So what really is happening at the level how asbestos causes a problem? Asbestos inhalation causes epithelial injury, which is activation of the macrophages. So injury activates the macrophage, simple terms here, causes chronic interstitial inflammation and fibrosis, right? So there's a lot of macrophage will cause fibrosis and calcification. Okay, what else we might have? So asbestosis with this fibrosis and fibrosis of the lung plus the pleura. This fibrosis increases the risk of lung carcinoma, which is your bronchogenic carcinoma, then your mesothelioma. So there is a way more chance that you're going to get bronchogenic carcinoma than you're going to get mesothelioma. But what did we talk about in mesothelioma? We said mesothelioma, it is associated with asbestosis. So that if you have mesothelioma, it's going to be with asbestosis. But with asbestosis, you're not going to look at mesothelioma in the first place, but you're going to think about bronchogenic carcinoma in the first place and then mesothelioma in the second place. That's an important fact. Okay. What else we might have? Okay, yeah. So let's recall the whole thing and move it on with the next one. So with asbestosis, what are we going to look at? We will see pulmonary fibrosis with the history of any of this. The thing will be in the lower lobes, ferruginous body will be seen, and you will see some calcified subdiaphragmatic pleural plaques. So again, pulmonary fibrosis, pleural plaque. You're not gonna see that white thing in the lungs, but in the pleura. Look, it's on the side. It's the pleural plaques. Okay, also pleural effusion. Three things: pulmonary fibrosis, pleural plaques, pleural effusions in the lower lobe, and the ferruginous bodies, and bronchogenic carcinoma greater than mesothelioma. And that's all for this one. Moving on with the next one is the berylliosis. Beryliosis, it is associated with exposure to beryllium, simple, in aerospace, important, and manufacturing industries. Okay, some other things that you will see, not only aerospace, not only these manufacturing industries. What do we mean by aerospace here? So they might say it works in NASA. Okay, uh, also nuclear weapons. So nuclear weapons, NASA, which is aerospace, and also manufacturing industries. These are all uh, the people who work in these areas can get berylliosis. Berylliosis. Okay. It's you're gonna have a granulomatous, non-caseating histology, and therefore occasionally responsive to glucocorticoids. Increased risk of cancer and cor pulmonale. Affects the upper lobes. Okay, berylliosis. One more thing here. It's gonna it's gonna look like sarcoidosis. So a lot of things look like sarcoidosis, but how do we differentiate this one now? I mean, for sure, why am I saying sarcoidosis? Here you have granuloma and non-caseating granulomas, right, affecting the lower upper lobes, and it is responsive to glucocorticoids. But how do you differentiate that? It's only simple exposure history. In sarcoid, you're looking at young black female. In berylliosis, you're looking at someone who has a NASA exposure or aerospace exposure, manufacturing industries like nuclear weapon industry. All of that is a clue, is the history that different that would tell you, okay, they're talking about berylliosis versus sarcoidosis. Um, okay, okay. One more thing, and that this granuloma will not only be in lungs, but also in the hilar lymph nodes and systemic organs will also be involved in this. So hilar lymph node in the lungs, you think of, I mean, that's why you had it versus sarcoidosis or even tuberculosis on that extent. But here you have a non-caseating, so you think about more sarcoidosis. So, yep, that's also, let's just review this berylliosis. It is the beryllium, these industries, non-caseating granulomas, and affects the upper lobes. And that's all for berylliosis. Now the next one is the coal workers pneumoconiosis. The coal worker pneumoconiosis is a prolonged coal dust exposure, which is going to cause macrophages laden with carbon, which causes inflammation and fibrosis. Also called black lung disease because coal is black, carbon is black. So you're going to have a black lung disease. Increases the risk of Kaplan syndrome. What else was increasing the risk of Kaplan syndrome? It was the first one, the asbestosis. Increased risk of Kaplan syndrome. It affects the upper lobes. Okay, how about this? Let's just make things simple. Everything else, as we talked about in the first line, everything affects the upper lobes except the asbestosis, which affects the lower lobes. If you look here, brucellosis, upper lobe, silicosis, upper lobes. Only one thing is lower lobe, which is asbestosis. Okay. And what else? Tuberculosis also affects the upper lobes in the primary infection. But in the reactivation, it's going to affect the lower lobes. Okay. So looking at again back here, coal workers, what do we have? Affects the upper lobe, small, round, nodular opacity seen on imaging. Anthracosis. What is anthracosis? There are asymptomatic conditions found in many urban dwellers exposed to sooty air. Okay. Let me see if I have anything extra. Okay, so yeah, let's talk about this Kaplan syndrome here. So Kaplan syndrome is what we said. You have an RA, rheumatoid arthritis present, and you have a interstitial lung disease. If you look here, intrapulmonary nodules and pneumoconiosis. So pneumoconiosis, we are talking about pneumoconiosis. Kaplan syndrome. Okay, so Kaplan syndrome is pneumoconiosis, which is the first thing. Second thing we have is rheumatoid arthritis, RA. And third thing we're going to have is our intrapulmonary nodules. Intrapulmonary nodules. And that's Kaplan syndrome. With this co-worker, again, an increased risk of Kaplan syndrome, just the same thing, because it is pneumoconiosis. On top of it, we are going to think about intrapulmonary nodules in RA. Well, anthracosis is someone who get exposed to that sooty air and develops, but it is asymptomatic condition found in many urban dwellers exposed to sooty airs. So it's sort of a mild. So what it is, it's anthracosis is the collection. Now these people are gonna have carbon, again, those carbon laden macrophages due to mild exposure, due to mild, again, important word is mild. Why? Because they're just exposed to the air, right? Exposure to the carbon in the air pollution, air pollution, and they're going to develop anthracosis. But these are the coal workers which are having the direct effect of that coal, direct effect of that air exposure. But whatever the air that went into the environment, a mild form causes anthracosis. Okay. So yeah, that's all we have for this one. So let's just highlight and recall the whole thing. We're talking about coal dust exposure. Prolonged coal dust exposure causes macrophages, fibrosis. Also it looks black lung disease. I mean, it's also called black lung disease. Increased risk of Kaplan, upper lobes. On imaging, you will see small round nodular opacities. Right, and the other disease is anthracosis, which is due to air pollution, and people will get that. Okay, and the next one is silicosis. Silicosis is associated with sandblasting, foundries, mines. Most high yield here is sandblasting. Okay, macrophages, they respond to the silica and release fibrogenic factors leading to fibrosis. It is thought that the silica may disrupt the phagolysosome and impair macrophages, increasing susceptibility to tuberculosis, increased risk of cancer, cor pulmonale, and Kaplan syndrome. Affects upper lobes. You will see eggshell calcification of the hilar lymph nodes on chest x-ray. What is an eggshell calcification? They haven't mentioned. Okay, so you have, let's say you have a lymph node here, right? So what is eggshell calcification of that lymph node? So this is a lymph node, let's say hilar lymph node. The calcification is just on the sides, on the periphery, on the rim of that lymph node. And that looks like an egg, called eggshell calcification. Okay. The silly egg sandwich I've found is mine. Well, it's not mine, so I don't know if this mnemonic is good or not. But what we can have for sure is your STB, silicosis. STB. So silicosis, tuberculosis, right? So silicosis leads to reactivation of tuberculosis or increases the risk of tuberculosis, right? So STB, you already know STB thing. But on top of that, what are we going to look for? Okay, so we are going to just highlight a couple more points here. Okay, yeah, one more thing is your sign symptoms. Silicosis is going to present with dyspnea, productive cough, occurring years after initial exposure to the crystalline silica. Okay, um, yeah, that's what we have. So let's highlight a couple of features, recall, move on. Silicosis, sandblasting, macrophage response and fibrosis after it responds to the silica. What that silica is going to do within the macrophages is mess up the phagolysosome, causes increased susceptibility to tuberculosis. Phagolysosome is a simple thing. You have macrophages, they engulf, they send the things to the phagolysosomes to the lysosomes to get destroyed. Uh, but if you have a disruption here, let's say you're not sending things to the phagolysosome, they will not get destroyed. When they not get destroyed, they will flourish, and that is what exactly we're seeing here in silicosis. And because you are messing up with this impairment, that disrupts the phagolysosome and impaired macrophage, that would lead to increased susceptibility of tuberculosis. Because if you recall tuberculosis, macrophage take them up, present them to the CD4 positive T cells, T helper 1 cells, and cause the damage, right? But if you cannot even destroy some particles, tuberculosis, I mean, they'll just live, thrive there, enjoy the time, free tea, But that's what we have here, silicosis. So let's look at this one. Eggshell calcification, high yield. Eggshell calcifications on the hilar lymph node on the chest x-ray, high yield. So here again, let's quickly go through this and move on to the next one. So what are we looking for? When we look at pneumoconiosis, one thing in common, maybe think about Kaplan syndrome, maybe think about most high yield pneumoconiosis is going to for sure lead to pulmonary fibrosis, right? But one thing you're going to know, okay, history is very high yield. Where the person has been working, that's very high yield, right? A chronic exposure to something is high yield. What have they exposed to? Is it a lower lobe or an upper lobe thing? If it's a lower lobe thing, then right away you could think about asbestosis, because that's easy. That's easy, right? It's simple. Lower lobe asbestosis. Asbestosis. Maybe try to make some mnemonic out of that lower lobe asbestosis thing. Asbestosis goes to the lower lobe. A goes to the lower lobe. Affects lower lobe. Yeah, if you guys can make any mnemonic, yeah, I'll be happy to look into it. But just remember somehow asbestosis, lower lobes, mnemonics are the best way. But I guess they already have a mnemonic. Wait, asbestosis from the roof, yes. So they affect the base. So whatever is from the roof affect the base, which is the lower lobe, and whatever is from the base, which is the earth, like silica, the coal, the berylosis, they will affect the roof. Easy. And how is this asbestosis from the roof? Well, if you look at this, shipbuilding, roofing, plumbing, and drywall application, textile industries, but I don't know how textile is in the roof. Well, just they're not from the earth, right? They're not coming from the earth base, which would be, well, if you look at this one, the coal is coming from the earth. Silica, okay, we can say silica is also coming from the earth, but I don't know how beryllium, which is used in, beryllium comes from the earth. Yeah, they're trying to say the source of that beryllium. It comes from the earth and it is used in aerospace, right? So I guess beryllium, the coal, the silica, all coming from Earth, so they will affect the top portion of the lung, which is the upper lobe, while the asbestosis, which comes from insulation, like roof, so they will affect the base, the lower lobes. Or if you can just make some wording mnemonic, that would be great too. But quickly, let's go with it. In asbestosis, you have pulmonary fibrosis, the pleural disease, and malignancies. Which malignancy most common? Bronchogenic carcinoma greater than mesothelioma. Increased risk of Kaplan syndrome. This is associated with like a couple more diseases, pneumoconiosis, so not sort of a specific here. What else you can have? You have pleural effusion will be seen. High yield, you will see calcification, where in the pleura, in the pleural plaques calcification, supradiaphragmatic. You will see calcified pleural plaques again. Ferruginous bodies are seen, which are rods like dumbbells, which are fusiform rods resemble dumbbells. They will be found in your alveolar sputum. High yield stain with the Prussian blue stain. Okay. Berylosis, simple beryllium granuloma disease, affects the lower lobes, and history is always high yield. Aerospace manufacturing industries, prolonged coal dust exposure, macrophage causes fibrosis, black lung disease, Kaplan syndrome, and that will cause, those macrophages will cause some small round opacities in the imaging, for sure, in the upper lobes. And silicosis is all about sandblasting. Macrophage respond to the silica, leading to fibrosis, but it disrupts the phagolysosome, so their susceptibility to tuberculosis increases risk of, again, the Kaplan syndrome. So Kaplan, and Kaplan. So I guess only one disease which does not do a Kaplan syndrome is your berylosis. So other than that, increased risk of Kaplan syndrome is with asbestosis, with coal and silica. So might as well you just think about all pneumoconiosis increases Kaplan syndrome. And what is Kaplan syndrome? It's basically a patient is going to come with all this history, with rheumatoid arthritis, with pneumoconiosis, whatever they have, and on top of that, intrapulmonary nodules. And that's all for this thing. Moving on to the next one. What do we have? We have acute respiratory distress syndrome, right? Acute respiratory distress syndrome. It is in pathophysiology. It is alveolar insult, which causes release of pro-inflammatory cytokines, which causes neutrophil recruitment, activation, and release of toxic mediators like reactive oxygen species, proteases, etc. What was the most common protease we talked about? Elastase. What was something that was trying to inhibit this elastase or trying to balance elastase? Alpha 1 antitrypsin, which is what? Anti-protease. Okay, moving on, which is capillary endothelial damage. Will occur. It causes increase in vessel permeability, causes leakage of protein-rich fluid into alveoli, leading to formation of intra-alveolar hyaline membrane. Arrows in A. Look at that. Intra-alveolar hyaline membrane will be seen. Intra-alveolar. Look at this line with the hyaline membrane. You will see. I mean, I don't know if you can see this, but here. Intra-alveolar hyaline membrane, right? And non-cardiogenic pulmonary edema, which is what is non-cardiogenic? When you look at the pressures, is normal PCWP, which leads to decrease in compliance. NVQ mismatch causes hypoxic vasoconstriction, causing increased pulmonary vascular resistance. A lot of things, right? A lot of things are going through here. There's a loss of surfactant. Also contributes to alveolar collapse, which is example in preterm infants, right? And drowning. So drowning messes up with the surfactant in the preterm infants because there is not sufficient production of surfactant by the time the baby is born. because the normal it was 35 weeks. So 20 weeks, 25 to 35. It starts production 25, ends by 35. So if it's a preterm infant, which is born before that 35-week period, then they will have less surfactant, causing alveolar collapse. Okay. The question is, you have all of this damage and causing all of this, right? VQ mismatches, every single thing with the alveolar insult causing hyaline membranes, air problem. Air is not going through the alveoli into the pulmonaries, causing VQ mismatches. Why? The question is, why all this happening? Well, it is happening because of all of these things. Sepsis causes alveolar insult. Aspiration pneumonia causes that. Burns, trauma, pancreatitis, drowning injuries. So all of these things, sepsis, aspiration pneumonia, burns, these are not a common thing that you think about. You say sepsis, you think about 10 other things, but they're trying to say, hey, listen, in sepsis, you also think about ARDS. In aspiration pneumonia, okay, you might think about it because it's the same system, right? In burns, you might not think about ARDS. In trauma, you might not think about ARDS. Pancreatitis, you might not think about ARDS. Drowning, well, sure, drowning, drowning is same system, so I guess, yeah. But these things are important then. So sepsis, burns, trauma, pancreatitis, ARDS. Alveolar insult occurs, right? And all of that remaining things will happen. But let's look at diagnosis first. How do you diagnose this? That, okay, it is ARDS. Well, it is a diagnosis of exclusion. What does that mean? That means you're going to look at every single thing, and then if you don't find anything, and you say, hey, we are tired, we checked everything, it's ARDS. Okay, diagnosis of exclusion with the following criteria, but also it has a criteria. You can't just say, hey, it's ARDS when there is not much alveolar insult or not much of these four things. So let's talk about what is ARDS criteria. Well, the criteria here is abnormal chest x-ray. You will see abnormal chest x-ray in almost anything. Bilateral lung opacities, looking at picture B. So you have diffuse opacities on bilaterally, and you have bilateral lung opacities, abnormal chest x-ray. Yeah, that's there. What else? Respiratory failure within 1 week. Okay, important. Respiratory failure will occur within 1 week of that initial alveolar insult. Third thing, you have a decreased partial pressure in the artery, oxygen, right? So partial pressure of oxygen in the artery and the FiO2 in the atmosphere, inhaled air, oxygen, it is decreased. So ratio is less than 300. Hypoxemia will develop due to increase in intrapulmonary shunting and diffusion abnormalities. So one thing here is decreased PaO2 to FiO2 ratio, which is about less than 300, and hypoxemia. And the fourth thing is symptoms of respiratory failure are not due to heart failure or fluid overload. So something is messing up with the respiratory system itself. It's not due to that. You have heart failure, you have all the backup of fluid causing respiratory failure, or you just have fluid overload, which is going into the respiratory causing this respiratory failure. It's just it is not due to those factors. So this criteria then becomes important, right? Because that's how you diagnose it. So again, ARDS, simple abnormal chest x-ray. Second thing, respiratory failure within 1 week of insult, decreased PaO2, hypoxemia. And fourth thing, respiratory failure not due to these two things, HFN, fluid overload. What are the consequences of it? You will have impaired gas exchange, which we talk about VQ mismatch, decrease in lung compliance, lung cannot expand, basically, and also pulmonary hypertension, because you have so much fluid there now. It's really hard to push the right ventricle to push into your in your pulmonary arteries because of pulmonary hypertension. How do you treat it? Well, treat the underlying this cause, because these all things are causing it. So treat that underlying cause. Mechanical ventilation. Start on them on mechanical ventilation, which decreases the tidal volume. Increase in PEEP. What is PEEP? It is the positive expiratory pressure, which keeps the alveoli open during expiration. Okay. Let me see if I have anything extra on this thing. Okay, yeah, so what do we have? Some extra features are in your ARDS. You are going to have, in your ARDS, you're going to have your, in your ARDS, you are going to have your, okay, so here what we're going to have is, we have type, so in alveolar insult, if you recall, you have type 1 and type 2 cells, right? So there's an injury to the pulmonary epithelium and the endothelium. Basically, type 1 and type 2 sites, in which case type 1 is your pulmonary epithelium. So alveolar insult, type 1 and type 2 are damaged. Pro-inflammatory cytokines. Um, that's important because what are the pro-inflammatory cytokines? They're going to be your TNF alpha and IL-1 and 6. So they're going to be high here. So, and they will all activate the neutrophils. Neutrophil will come, activate, release the toxin, release those mediators, causing capillary endothelial damage, which causes, when you cause the damage to the epithelium, endothelium is going to cause increase in permeability, which will cause a protein-rich fluid in the alveoli, and that will lead to that protein-rich alveoli that goes out, causes hyaline membrane. The high yield point is hyaline membrane is non-specific. Hyaline membrane formation is a non-specific. So any time that you have the capillary endothelial damage and protein-rich fluid goes out, it's going to cause hyaline membrane. It is non-specific to ARDS or NRDS. Okay, and also you will have not only hyaline membrane, but also you will have a non-cardiogenic pulmonary edema. Pulmonary edema, just remember that. Because of that leakage of all that fluid, it causes hyaline membrane and it causes pulmonary edema. Makes sense? And non-cardiogenic because you have a PCWP normal, meaning it's not due to from the cardiac cause. Okay. What else? Give me 1 second. Yep. Great. Okay. So you have pulmonary edema, right? On top of it, because you just develop a pulmonary edema, you're gonna the lungs will not be compliant anymore because it's all filled with fluid. The decrease in compliance. Because you have pulmonary edema now, and hyaline membrane formed right here, so the gas exchange will not occur. When the gas exchange does not occur, you will have a VQ mismatch. And when you have the VQ mismatch in your lungs, you're gonna have hypoxic vasoconstriction. Whenever you cannot have the oxygen within this pulmonary vasculature, they will go into constriction, vasoconstriction. So hypoxic vasoconstriction will occur. That hypoxic vasoconstriction is going to cause your pulmonary increase in pulmonary resistance for sure because of vasoconstriction. More importantly, it's going to cause pulmonary hypertension. Pulmonary hypertension, which is written right here, pulmonary hypertension. So hypoxic vasoconstriction eventually causes pulmonary hypertension. All right, and these are all the causes that causes it. That's easy point. Other than that, what else you might have with the pain? So this is going to be the person who comes in, let's say, an alcoholic who took alcohol, heavy alcohol, and this patient with pancreatitis is going to come with ARDS with all the lung problem. But on top of that, with the specific pancreatitis things, increase in amylase and lipases, right? With this aspiration pneumonia, it's going to be like a person who is unconscious, aspirates, causes pneumonia, aspirates on what? Aspirates simple on the gastric content. Okay. Uh, Trauma can also be one of the causes of ARDS. As sepsis, most high yield is sepsis, and this is ARDS as a diagnosis criteria. On top of it, we have management, right? So management is this hypoxia, which is right here, is going to be refractory. So no matter how much you give oxygen therapy, this hypoxemia will not be fixed. Why? Because it's not about the oxygen here, it's about the diffusion. The gases are not being diffused because of that intrapulmonary hyaline membrane formation, because of that alveolar edema, fluid in the alveoli. So there is no fluid to go out. There is no oxygen that's going to go out of this place. So no matter how much you give O2 from outside, it's going to be refractory hypoxemia. So what do? You give them increase in PEEP. What is PEEP? It is your positive expiratory pressure. And what is this going to do? It's going to increase your FRC to keep the alveoli open during expiration. So why are we saying expiration? Why not inhalation? Because when you expire, the alveoli collapse, and when they collapse, it's really hard to open when you don't have enough. It is all fluid, and you don't have surfactant. So you keep these alveoli open while you're expiring through giving PEEP pressures, right? So this is high yield point, increase in PEEP, and it is eventually going to cause increase in FRC. That's also high yield, or it does cause increases in FRC. So yeah, that's pretty much what we have for ARDS. Moving on with sleep apnea. Sleep apnea, it is a repeated cessation of breathing for greater than 10 seconds during sleep, leading to disrupted sleep and daytime somnolence. Diagnosis confirmed by a sleep study. So you have the cessation, meaning you're stopping. You do stop breathing for what? For more than 10 seconds? And that just doesn't happen one time. That's occurring like hundreds of times each night, or more than tens of times each night, or maybe hundreds, who knows, depending on if it is a mild, moderate, severe, right? And that would for sure cause daytime somnolence. For sure, although you were sleeping, but the sleep you had is, you didn't, basically your mind wasn't sleeping, and you would have a daytime somnolence. And what do? You go for sleep study, in which they put on electrodes on your mind, try to see how many times with that sleep cessation your brain is going to get up. And they say, okay, he was sleeping for 5 hours, 6 hours, and his mind, he was getting up because he couldn't breathe. He was getting it for like 100 times, 10 times, 20 times. I don't know, maybe depends on, again, mild, moderate, severe, all that, but it shouldn't happen normally. For more than 10 seconds, no way. Okay, if you see more than 10 seconds, think of sleep apnea. Nocturnal hypoxia, which is a systemic and systemic and pulmonary hypertension, which leads to, one more time. Nocturnal hypoxia. So in the night, you're going to have hypoxia. When you're going to have hypoxia, you're going to have pulmonary hypertension. Again, the same thing. With hypoxia, you will have vasoconstriction. Vasoconstriction causes pulmonary hypertension, right? So systemic and pulmonary hypertension, and all the arrhythmias, AFib, flutter, sudden death can occur with sleep apnea. High yield. Hypoxia causes increase in EPO release, which is erythropoietin from the kidneys, causes increase in erythropoiesis, causes increase in hematocrit. Okay. Uh, Now, in sleep apnea, we have a couple of sleep apneas. We have got obstructive sleep apnea, which is also known as OSA. It is respiratory effort against the airway obstruction. So, respiratory effort is against the airway obstruction. So, you have some sort of obstruction, that is, your lungs are trying to have some force against that obstruction. So, your partial pressure of oxygen is usually normal during the day, but associated with obesity. What is the obstruction? Obesity. Loud snoring is one of the things. Because you so much have obstruction, you can have a very loud snoring. Daytime sleepiness, again, same thing, because you're getting up uh, more than 10 seconds during your sleep. So you won't have daytime sleepiness. It's usually caused by excess parapharyngeal, oropharyngeal tissue in adults, as again, airway obstruction. Um, Adenotonsillar hypertrophy in children. Important. Children are not obese, let's say, but they could have adenotonsillar hypertrophy. Treatment is again weight loss. Simple weight loss. CPAP, high yield. If you can do weight loss, you got to go into CPAP. Okay, dental devices. If you have something with the that can hold the mouth open, I guess. Hypoglossal nerve stimulation. What is this going to do? I think this was about a tongue. It's going to deviate the tongue, make the airway more open, and so that you can breathe more. Because one of the things in OSA is the tongue goes up on the roof of the floor, so you have obstruction. So if you can stimulate the tongue so that the tongue is right here, there's a more open area for the air to go, right? Upper airway surgery can be done. So this is all about OSA, which is obstructive. Again, the name here implies obstructive. Obstructive obesity, most common. Other than that, you can just think about any obstruction to the airways causing sleep apnea. Then you have central sleep apnea. Central is all about the brain, right? CNS, central brain. So impair respiratory effort due to CNS injury or toxicity, or congestive heart failure, opioids. Opioid also causes a decreases the respiratory drive, right? May be associated with chain stroke respiration, which is oscillations between apnea and hyperapnea. So apnea is when you don't have any. Let's have a normal breathing pattern here. Apnea, there is no breathing. Hyperapnea, there is hyperapnea. I guess there is. Wait, what is hyperapnea? I have no clue. So let's look into that first. Here, what I can do. Google. Hyperapnea. Okay, hyperapnea is a medical categorized by increased rate of depth of breathing. Increased rate and increase in depth of breathing. Okay, nice. Okay, we have apnea and increase. Okay, hyperapnea. Okay, makes sense. So this is again, I guess it is a chine stroke breathing pattern. And what do we see here? We will have apnea oscillations. There will be oscillations between apnea and hyperapnea, and that will be known as uh, chine stroke. Chine stroke respirations. Treatment is again is PEEP, positive. Wait. positive airway pressure. Okay, then you have this last sleep apnea, which is obesity, hypoventilation syndrome, also called Pick-Vikian syndrome. Pick-Vikian syndrome. Obesity. What is obesity? Greater than 30 BMI, which which causes hypoventilation. That leads to increase in the partial pressure of carbon monoxide during waking hours because of retention, and decrease in PaO2 and increase in PaCO2 during sleep. So what is all this happening? You have obesity so much that you're going into hypoventilation due to your obesity, specifically obesity. And that because you're hypoventilating, you're retaining your carbon dioxide, right, in the waking hours, and during sleep you're also retaining, of course, yeah, you're also retaining increase in PaCO2. You're still retaining the partial pressure of carbon dioxide in sleep as well. But one important thing is, during sleep you're decreasing the oxygen level, but when you're waking up in normal hours, you are not messing up with your oxygen levels. So that's important. Treatment is weight loss, again, PEEP, positive airway pressure. So again, what is all this all about? Let me erase this. Simple things. Okay, simple. Just review it now. Sleep apnea. Apnea of greater than 10 seconds is called sleep apnea. It's going to cause daytime somnolence. Sleep study is the way to go. You have nocturnal hypoxia and hypoxia itself. Nocturnal hypoxia will lead to systemic and pulmonary hypertension. How it's going to cause systemic hypertension? Because when you have hypoxia, your SANS gets activated, sympathetic nervous system. When the system when your SANS, sympathetic nervous system, gets activated, it's going to release all the hormones and everything to vasoconstrict the vessels, so that everyone can have the normal oxygen. Everyone can get the normal oxygen, right? And that is why you're going to develop systemic hypertension. Why would you develop pulmonary hypertension? Because when you have hypoxia, one of the things in the lungs are that when you get hypoxia of the lung, it causes vasoconstriction. Just hypoxia itself causes vasoconstriction within the lungs, leading to systemic and pulmonary hypertension. Okay, so that's high yield. On top of that, because of that hypoxia, you're going to increase your EPO release, cause increase in erythropoiesis. Obstructive is due to obstruction. Obstruction could be anything, right? And how would you treat it? You can treat it by either removing that extra tissue or hypoglossal nerve stimulation or surgery. Central is all about CNS, opioids, CCC, giant stroke respirations, apnea, hyperapnea. Treatment is PEEP. Obesity is all about obesity greater than 30, which causes hypoventilation because you have so much fat or so much that you cannot breathe normal. You have hypoventilation because of obesity. So much excess fat is there, or excess tissue is there, that you can't breathe normal. When you can't breathe normal, you will have hypoventilation. When you hypoventilate, again, you're going to increase your partial pressure of carbon monoxide. When you increase the carbon pressure of monoxide, what's going to happen? Are you going to develop respiratory acidosis or respiratory alkalosis? When you check the ABGs, you will see that you might have gone into your, that's if you have a lot of carbon monoxide, right? So you can go into respiratory acidosis. Okay, because of retention of carbon dioxide, right? And that's only through, you can check ABGs and check that out. But treatment is again weight loss because of obesity and PEP. So PEP should be in the back of the pocket. wherever you see something with a ventilation or something hard to breathe, just give PEEP. Okay, moving on with the next one is called pulmonary hypertension, very high yield topic. Pulmonary hypertension is about elevated mean pulmonary artery pressure to greater than 20 mmHg at rest. Results in what does it do? This hypertension would result in atherosclerosis, medial hypertrophy, intimal fibrosis of the pulmonary arteries, and plexiform lesions. Increased pulmonary vascular resistance causes increase in RV pressure that leads to increase in right ventricular hypertrophy, which we will see as parasternal heave on examination, eventually causing right ventricular failure. So there are a couple etiologies for this pulmonary hypertension, so let's look at each one of them. So the first one is the pulmonary arterial hypertension, group 1. It is idiopathic. Females have more common than males. It is if heritable PH, which is pulmonary arterial hypertension, can be due to inactivating mutations in the BMPR2 gene. BMPR2 gene, which is normally inhibits the vascular smooth muscle proliferation. It has a poor prognosis. Pulmonary vascular endothelial dysfunction results in increase in vasoconstriction. So you have endothelial dysfunction, which causes increased vasoconstriction, example, endothelin release, and decrease in vasodilators, for example, decrease in nitric oxide and prostacyclins. Other causes include some drugs like amphetamines, cocaine, connective tissue diseases, HIV infection, portal hypertension, congenital heart failure, schistosomiasis. Okay, so what was the most important thing? That was your inactivating mutation in your BMPR2 gene. What could be any other factor? It could be anything, drugs or infections. But what's happening in your pulmonary arterial hypertension is specifically that you have endothelial dysfunction due to either these causes or genetic mutation in that. You have endothelial dysfunction causes increase in vasoconstriction, increase in vasoconstrictors, which are your increase in endothelin release. There's increase in endothelin release, and on top of it, not only one thing, but increase in vasoconstrictors, but decrease in vasodilators, which is your nitric oxide and prostacyclins. Right. The next one is your left heart disease. What is left heart disease? It is caused by causes include systolic, diastolic dysfunction and valvular diseases. Then you have group 3, which is lung disease or hypoxia. So destruction of the lung parenchyma, which is COPD, lung inflammation, fibrosis, interstitial lung disease, hypoxic vasoconstriction, obstructive sleep apnea, living in high altitudes. The other one is chronic thromboembolic disease, recurrent microthrombies, causing decrease in cross-sectional area of the pulmonary vascular bed. Multifactorial causes include hematologic, systemic, metabolic disorders, along with compression of the pulmonary vasculature by a tumor. So what do we learn from all of this? Well, we learned specifically simple things. What did we learn? We learned, okay, we could have pulmonary arterial hypertension in which the arteries are involved. Through it, we can have pulmonary hypertension, or we can have left heart diseases can lead to pulmonary hypertension. Lung diseases, which we talked about all in this chapter, can lead to pulmonary hypertension. Thromboembolic form can lead to pulmonary hypertension, or anything multifactorial, hematologic, systemic, metabolic disease can lead to pulmonary hypertension. So what is pulmonary hypertension? That is more important. So what is pulmonary hypertension? You will see when you have increase in the pulmonary arterial pressure greater than 20, you call it pulmonary hypertension. And that will lead to more complications like atherosclerosis, medial hypertrophy, medial hypertrophy, intimal fibrosis, right? So we're talking about intima. What's going to happen to intima? Fibrosis. What's going to happen to the media? Medial hypertrophy. So media is will be way bigger, hypertrophy. And what's going to happen to your plexiform? You will see plexiform lesions, uh, and fibrosis, right? Fibrosis, hypertrophy, plexiform lesions. What is all that going to lead to? You know, well, with pulmonary hypertension, you will lead to resistance of fluid from the right ventricle. So if you just recall, right ventricle sends the fluid into your pulmonary arteries, right? So when there is a resistance here, guess what? You will not be able to send the fluid into your pulmonary arteries. So your RV is going to increase. Right ventricular pressure is going to increase right here, right? The pressure is going to go back in the right ventricle. So when the pressure goes back, it causes hypertrophy of the right ventricle. So right ventricle hypertrophy. How do you see that on examination? Parasternal heave. And eventually the heart is going to give up. He's going to say, oh my God, I can't do this anymore. So I'm just giving up. Leads to right ventricular failure. Causes: idiopathic BM2R gene mutation. Any other cause: left heart disease, lung disease, thromboembolic, multifactorial. Okay. Uh, what are the drugs? And we will talk about the drugs later on, but some things that we look at, uh, because you have increase in endothelin here and decrease in prostacyclins, guess what we're going to do? We're going to be looking at some things which will inhibit this endothelin release, and some things which will stimulate your vasodilators to fix the problem of pulmonary hypertension. Bosentan, you'll see that it's going to come up. So bosentan. Okay, moving on with the next one. What do we have? Pulmonary physical finding. We have a physical finding in select lung diseases. So what are the physical finding in select lung diseases? So what are the abnormalities first? Well, the abnormalities here are: you have pulmonary pleural effusion, atelectasis, simple pneumothorax, tension pneumothorax, consolidation, and consolidation is basically lower pneumonia, pulmonary edema, right? So what's going to happen to your okay, what is pleural effusion? Is basically fluid, right? Excess fluid. So I'll just write fluid here. Atelectasis is about the collapse. So the whole lung has been collapsed, or some part of it collapsed. Alveolar collapse has occurred. Pneumo is about air, but in a simple pneumothorax is different than the tension pneumothorax, but pneumo is air. Consolidation is like a in lobar consolidation, you're looking at pus, and pulmonary edema is just fluid, right? So what's going to happen? So, and this is pulmonary, and this is your pleural fluid, different. So what's going to happen to your breath sounds? Well, the breath sounds is going to decrease in all of these things, right? And here you will have bronchial breath sounds. Uh, you will see just bronchial breath sound in consolidation, which is pus or fluid, right? You will see bronchial breath sounds. But the other way, I mean, breath sounds are just decreased in the rest of them, right? Percussion is important. What are you gonna do in percussion? So when you have a fluid, or you're gonna have a dull percussion. Just think about it when you have, like, let's say a barrel. I mean anything with when you put the fluid in and you tap it, you will feel that dull percussion. But when will you feel that hyper resonant, meaning the echoing? The echo occurs when there's air, right? So with the pneumothorax, either be simple or tension, you will just feel the air, right? So that's hyper resonant. And what is here? Again, same thing as dull, because uh, it is pus or fluid, so it's dull. Consolidation is dull. Percussion. So what do we learn? We say in percussion, if it's a fluid, it's anything fluidy, then it's going to be dull. Anything airy is going to be hyper resonant. Hyper resonant. Fremitus. What is fremitus? So So it's basically the fremitus is a tactile vibration used by voice and transmitted to the chest wall. So if you recall, you sometimes you say to patient, say something, 99 or something, right? It's called tactile fremitus. Tactile fremitus, again, what is it? It's a vibration used by voice. So when they are saying 99, it is transmitted to the chest wall and you're hearing it. And do you see it is increased or decreased? So it is decreased in your fluids, except in your pus. So fluid, it can travel through fluid. It does not travel through fluid, right? But with consolidation, it doesn't even go there, so it becomes more. You can hear it more. Look at it one more time. What I'm trying to say here is, when you say 99, no matter you have fluid or air, everything is going to decrease. No matter you have fluid or air, everything is going to except the consolidation, which is about the whole lobe is consolidated to a point that nothing goes through it. So when the nothing goes through it, it's going to be increased. Okay, and let's say look at the tracheal deviation. What do we have in the tracheal deviation? None if small in the pleural effusion, but it's going to be away from the site of lesion if large. So PE, pulmonary effusion, not PE, but pulmonary effusions can lead to away. So trachea would deviate away from the lesion if it is large. Atelectasis is towards. And again, tension pneumothorax is away. So how can we know this one now? So the simple way to think about it is as this. Atelectasis is the collapse, right? So because let's say the left lung gets collapsed. So the trachea is deviated towards that lesion because the force is towards that side. It has collapsed. Okay. On the other hand, if you have air or fluid, a lot of air you need, right? A lot of air you need. Or you have fluid. A lot of fluid you need. Or you have air in the pneumothorax, right? It's going to be away. So air, fluid, away. While atelectasis is just going to be towards the collapse. Okay, and the last one is just in consolidation, you don't have any tracheal deviation. The tracheal deviation, just think about atelectasis. Atelectasis is towards. This is the only one, right, which is towards. So just remember, atelectasis, which is maybe pulling the trachea towards the side of lesion. And anything else, if you see a tracheal deviation, it's going to be away. Right? And if it is away, then you think about, okay, it's a pleural effusion, it's a pneumothorax. But how do you differentiate these two? Because tactile fremitus is decreased in both. Breath sound is decreased in both. How do you see the difference between these two then? The only difference is going to be hyperresonant and dull percussion. So here you have hyperresonant, and over there you have dull percussion. So again, fluid is going to be dull. So let's actually erase all of this and make things simple. Okay, just going through it now. Review of this physical finding of select lung disease. Pleural effusion is about fluid. Fluid, you will have decrease in, fremitus is decrease in everything except your consolidation, so forget about that one. But fluid will cause dull percussion. Air would cause hyperresonant. When you hear hyperresonant, you know it's air. It's like a drum, empty drum with a lot of air in it. Hyperresonant, right? But if you have fluid, it's just dull, right? So looking at the tracheal deviation, atelectasis is the only one which causes the trachea towards the lesion, right? Because of that, let's just say maybe as a mnemonic way, you can say, okay, atelectasis, the mass is pulling it towards that side, towards wherever the lesion is, toward the site of lesion, right? Uh, while in the fluid or in the air, you just have away from the lesion. The only way that you're going to know if it's a fluid or the air is is it dull percussion or is it a hyper resonant percussion? If it's a dull percussion, you're looking at pleural effusion, which is a fluid. If it is an air, then you are looking at tension pneumothorax with a hyper resonant percussion. Okay, so okay, yeah, that's all for this one. Moving on with the digital clubbing. Digital clubbing, increased angle. You can see the angle is increased right here. The increased angle between the nail bed and the nail plate greater than 180 degrees. Pathophysiologically not well understood. In patients with intrapulmonary shunts, platelet and megakaryocyte, they will become enlarged in the digital vasculature, which lead to release of prostaglandins, uh, PDGF, and VEGF. My bad, it's platelet-derived growth factors and vascular endothelial growth factors. Can be hereditary or acquired. Causes includes respiratory diseases, idiopathic pulmonary fibrosis, cystic fibrosis, bronchiectasis, lung cancer, or cardiovascular diseases, cyanotic congenital heart disease, infections, lung abscess, tuberculosis, and other IBD, not typically associated with COPD or asthma. So many causes, right? Digital clubbing, it is very non-specific, but so many causes that can lead to it. And what are the causes? Basically, you have intrapulmonary shunting. If you have intrapulmonary shunt, if you have a problem in the platelet and megakaryocyte become large in the distal vasculature, they're going to cause digital clubbing. How? By increasing in the platelet-derived growth factors and vascular endothelial growth factor high yield. And could be hereditary, acquired, and all of these factors play in the role. That's called digital clubbing. Okay, moving on with the next one. What do we have? Atelectasis. Atelectasis. Atelectasis is, again, you have the collapse, alveolar collapse. Right upper lobe collapse against the mediastinum in A. If you look here, right upper lobe has collapsed. Right, you can see it here. It has collapsed against mediastinum in A. Multiple causes could be there. Could be obstructive disease, obstructive causing alveolar collapse, compression, contraction, adhesion. So let's look at obstruction. Airway obstruction prevents new air from reaching distal airways. All air is resorbed, foreign body, mucus plug, and tumor. Compression is external compression on the lung, decreases the lung volumes. Example, space occupying lesion, pleural effusion. Contraction, cicatrization, scarring of the lung parenchyma that distorts alveoli. Example, sarcoidosis. Adhesive, due to lack of surfactant and RDS in the premature infants. Decrease via incentive spirometry or increase in PEEP during mechanical ventilation. Important thing is looking at obstructive. So obstructive here is you have, look at this red point, you have obstruction here. So look at this, you have alveolar collapse here because of that obstruction to the upper bronchus, right? But look at the pleural effusion, air or tumor. Again, you have a collapse of this alveolar at the lower lung because of pleural effusion, air or the tumor, right? This is all about compressing this lung tissue, right? Then you have this contraction. Contraction occurs when you have scarring of the lung tissue, and contraction would be, example is sarcoidosis. That contraction occurs with the sarcoidosis. The last one is adhesive. Adhesive is the surfactant. You don't have surfactant. So due to lack of surfactants and RDS and everything, so the lung is not able to open itself because you don't have surfactant to decrease the surface tension of the lung, right? So all of these are the reasons of alveolar collapse. And how can you fix it? You could decrease that alveolar collapse by incentive spirometry or giving PEEP, increasing PEEP. So this can be fixed here. Okay, and that's all for the atelectasis, again, which is the alveolar collapse. Okay, moving on with the pleural effusions. Pleural effusion is excess accumulation of fluid between the pleural layers, which causes restrictive lung expansion during inspiration. Can be treated with thoracentesis to remove reduced fluid based on the Light's criteria. Fluid is consistent with exudate if pleural fluid protein serum pleural fluid proteins to serum protein is greater than 5. So again, the mnemonic here is simple. Exudate is going to be greater than 0.5. Everything with the exudate is just going to be more. Okay, one thing we're just looking here is 0.5 in the exudate. Pleural fluid LDH to serum greater than 6. Or pleural fluid LDH is greater than 2/3 of upper limit or normal serum LDH. So everything that is increased is going to be your exudate. 0. Greater. So exudate you will see is greater than 0.5 of your pleural fluid protein, serum protein, and greater than 0.6 of your LDH and serum LDH concentration. You call it exudate. And in other way, the transudate is going to be less. So the mnemonic here is exudate is extra. E for exudate, E for extra, and extra means, you always know extra means more. Greater than 0.5, 0.6. Well, the other way is this transudate. Transudate is less than 0.5, 0.6. Okay. So what is exudate now? Let's talk about that. So exudate is a cloudy fluid, important, because of a lot of cellular content in it, due to infection, pneumonia, tuberculosis, malignancy, connective tissue disease, lymphatic, chylothorax, trauma. Often requires drainage due to increase of infection. So you can drain it, you have to drain it, requires drainage due to increased risk of infection. So if you look in this picture in exudate, what do we see? We're seeing that, okay, there's a vascular permeability, increase in vascular permeability, which causes all of these fluid, the inflammatory cells, the protein to leak out between the pleural layers, causing pleural effusion, right? So increased vascular permeability causing all of these things to come out of that vessel, causing pleural effusion. On the other hand, and see, this looks cloudy, not clear, right? Well, on the other hand, you have a clear fluid in the transit, which is hypocellular, meaning not a lot of cells are there. Why is that happen? Because of increase in hydrostatic pressure. So you have increase in your hydrostatic pressure right here. That increased pressure causes what? That increased pressure would cause the fluid to leak out, but not a lot. Just the fluid comes out. There is no inflammatory cells. There is no proteins. Just the fluid. So it looks clear. Exudate looks cloudy because it's a lot of bunch of things coming out, right? And why would you increase the hydrostatic pressure? It is seen in your heart failure or sodium retention, and decrease in oncotic pressure could also be seen, which is seen in nephrotic syndrome and cirrhosis. So either you're increasing hydrostatic pressure and or, so plus minus, you're decreasing the colloid oncotic pressure, which leads to transudate. Okay, and yeah, that's that's pretty much it. Let's review it quick and move it on to the next. So we have, again, simple things. Pleural effusion is the excess accumulation of fluid between the pleural layers, which would restrict the lung to expand during inspiration. Thoracentesis you can do thoracentesis to remove that excess fluid. It is all based on Light's criteria, which means the exudate has extra things, meaning greater, all the greater stuff, and the transudate has lower things, less stuff. So so Light criteria states that exudate is there if fluid protein to serum protein content is greater than 0.5. Pleural fluid LDH level to this serum LDH level is greater than 6, and pleural fluid LDH is greater than 2/3 of the upper limit of the normal serum LDH. Exudate is all about cloudy. It occurs due to some infections, malignancies, or connective tissue, lymphatic trauma, any cause, right? But transudate is specific to your increase in hydrostatic pressure or decrease in oncotic pressure, which is caused by heart failure, sodium retention, nephrotic syndrome, cirrhosis. Okay, and it is going to be clear fluid, and that's all for this topic. Let's look at pneumothorax. What is pneumothorax? Well, pneumo, air, right? Pneumothorax is about air in the thoracic cavity. Accumulation of the air in the pleural space is pneumothorax. You'll see dyspnea, uneven chest expansion, chest pain will be there, decrease in tactile fremitus, hyperresonance, diminished breath sounds, all are on the affected side. So this thing you can just look at from the table back there, because that's going to make sense more, right? But other than that, what is pneumothorax is the accumulation of air in the pleural space, causes dyspnea, uneven chest expansion, and chest pain. Now you have primary spontaneous pneumothorax, secondary traumatic, and tension. So let's look at each one of them. So primary spontaneous pneumothorax is due to rupture of the apical subpleural blebs or cysts, occur most frequently in tall, thin, young males associated with tobacco smoking. So again, primary meaning the problem is there. It initiates from there. There's a rupture of these subpleural blebs or the cysts, which causes the air to go out into the pleural space, causing pneumothorax, right? And which patient are you going to see it in? In tall, thin, young males associated with tobacco smoking. The secondary spontaneous pneumothorax is you have due to diseased lung, for example, Bullion emphysema, Marfan syndrome infection. You already have a diseased lung. So in that you can develop a secondary pneumothorax because of those diseases, and mechanical ventilation with use of high pressure can lead to barotrauma. So when you use a mechanical ventilation in these patients, it can cause a barotrauma. Then you have the traumatic pneumothorax. It is caused by blunt refracture, penetrating gunshot wound, iatrogenic, for example, central line placement, lung biopsy, barotrauma due to mechanical ventilation or trauma itself. So traumatic pneumothorax, as the name says, you have a trauma or all these are trauma, they cause pneumothorax. Tension pneumothorax can be from any of the above, right? But the air enters the pleural space but cannot exit. So you have air that goes into this, let's say this is a lung, and here's the pleural space. Air is going in, but it has no way to go out. So it is just going in and in, not going out, causing lung to collapse more and more. Increased trap air causes tension pneumothorax. Trachea would deviate away from the affected lung. Air fluid both cause away from the tracheal tracheal deviation will be away from the site of lesion away is the main thing. May lead to increase in intrathoracic pressure, right? Because you have so much pressure here, you can increase intrathoracic pressure, which is going to cause mediastinal displacement. Mediastinal displacement, king of IVC, high yield, causes decrease in venous return, causes decrease in cardiac output, causes obstructive shock. Because when you decrease cardiac output, you have obstructive shock, which is going to be seen as hypotension with tachycardia. Tachycardia, why tachycardia? Because heart is trying to push fluid out as much as it can, but you just don't have the preload, causing hypertension and tachycardia. JVD distension, JVD basically jugular venous distension. It needs an immediate needle compression and chest tube placement. Immediate needle compression and chest tube placement. Okay, so let's recall this whole thing and let's go with it. Pneumothorax is all about accumulation of air in the pleural space. You will have dyspnea, uneven chest expansion, and chest pain. And the physical examination, you already know that one. So no need to mention that, except that it's the trachea would deviate away from the lesion if you have a tension pneumothorax. So the primary is all about the primary, that you rupture that primary apical subpleural bleb or cyst, which is seen in your tall, thin young male, who smokes. So when you look at tall, thin, you already know he's smoking. I mean, assuming you shouldn't assume anything, but smoking. If you have a tall, thin young male who smokes, at least it can lead to primary spontaneous pneumothorax. Secondary pneumothorax is due to any lung disease. Traumatic pneumothorax is due to some trauma. Tension pneumothorax is any of these in which the air does come in but has no way to go out. Air trapped causes tension pneumothorax. Trachea deviates, and that because air has trapped here now in the lung, it increases the intrathoracic pressure. That increase in intrathoracic pressure is going to kink on IVC, decreasing IVC, causing obstructive shock. That obstructive shock will be seen as hypertension, tachycardia. Jugular venous distension will be seen because fluid is not able to come down. You will see JVD. Needs immediate needle decompression, and chest tube placement. And that's all for pneumothorax.